Hey everyone, welcome back to the channel. Today we're tackling one of the most high-yield topics in all of respiratory medicine, the pharmacotherapy of asthma. Whether you're a medical student prepping for exams or a physician dusting off the latest guidelines, this is your one-stop resource. I'm going to walk you through every drug class, the mechanisms, the doses, and exactly what GINA, NAEPP and the UK guidelines say in 2024 and 2025. So grab a coffee, hit subscribe, and let's get into it. Before we touch a single drug, you have to understand what we're actually fighting. Asthma is two things happening at once: chronic airway inflammation and variable airflow limitation. On the inflammation side, you've got the type 2 high pathway for IL-5, IL-13, Ig, eosinophils, driving mucus, swelling, and long-term remodeling. On the other side, bronchoconstriction, the smooth muscle clamping down when you hit an allergen, cold air, or a virus. Here's the punchline that drives everything: corticosteroids and biologics fight the inflammation. Bronchodilators just relieve the squeeze. That's exactly why SABA-only treatment is dead. It never touches the fire underneath. So how do we frame treatment? Two buckets: controllers and relievers. Controllers are the daily meds that keep asthma quiet. Your ICS backbone, ICS, LABA combos, LAMAs, and biologics for the tough cases. Relievers are your rapid rescue, and increasingly that's ICS formoterol, not plain SABA. And when we say control, we mean two things: symptom control today. The daytime cough, the night waking, the reliever use, and future risk tomorrow, preventing exacerbations and lung decline. We measure it with ACT or ACQ scores, spirometry, and peak flow. Remember, if someone's reaching for their reliever all the time, that's a red flag, not good control. Let me give you the big picture map, because if you get this framework, everything else clicks. 3 families. Bronchodilators open the airway fast: SABAs, LABAs, and LAMAs. Anti-inflammatories calm it down slowly: ICS, LABA combos, leukotriene modifiers, and oral steroids. And then biologics, the precision weapons, targeting specific cytokines in severe type 2 disease: anti-Ig, anti-I5, anti-IL4, and anti-TSLP. Here's my one-line mnemonic: bronchodilators open, anti-inflammatories calm, biologics target. Keep that thread in your head, and the whole lecture hangs together. Let's start with the classic: short-acting beta-2 agonists, your salbutamol, your albuterol. Mechanism: they hit beta-2 receptors, crank up CAMPI, and the smooth muscle relaxes. Onset in about 5 minutes, lasts 4 to 6 hours. That's your rescue response. But here's the catch: it's purely symptomatic. Zero anti-inflammatory action. Side effects come from beta stimulation everywhere else: tremor, palpitations, tachycardia, and dose-related hypokalemia. And the exam pearl: you cannot miss 3 or more canisters a year, or daily use predicts exacerbations. That's why GINA scrapped SABA-only therapy. Always pair it with an ICS. Long-acting beta-2 agonists. Same mechanism, but now we're talking 12 hours or more. Salmeterol is slow to start. Formoterol kicks in within 5 minutes. which is why formoterol can pull double duty as a reliever. But here's the single most important safety point in this whole talk. LABA monotherapy increases the risk asthma death. That's the historic black box warning. The fix: give it with an ICS and the risk vanishes. That is the entire reason fixed dose ICS LOBA inhalers exist, to guarantee the LABA is never taken naked. So the rule is simple: never a LABA without an ICSS ever. This is the backbone. If you remember one drug class, make it inhaled corticosteroids. They bind the glucocorticoid receptor, switch off inflammatory genes, and drop your cytokines, eosinophils, and airway hyperresponsiveness. Bonus: they restore beta-2 sensitivity, so they synergize beautifully with LABAs. Side effects are mostly local, oral thrush, and a hoarse voice, which is why you rinse and spit and use a spacer. Go high dose long term, and you start risking bruising, cataracts, and bone loss. And here's the pearl: the dose response curve is flat. Low dose ICS gives you most of the benefit, so escalate the regimen, add a LABA before you crank the ICS to the max. Now, the paradigm shift that changed modern asthma care. One inhaler ICS formoterol, used for both maintenance and relief. Every single rescue puff also delivers anti-inflammatory steroid. 3 acronyms, same idea. AIR is as needed only in mild asthma. MART is daily plus reliever from step 3. And SMART is just the American name for MART. Why does it matter? As needed ICS formoterol cuts severe exacerbations by around 60% versus SABA alone in mild asthma. 60%, one catch. It's off-label in the US, which is why American guidelines are more cautious. And never use a salmeterol inhaler as a reliever. It's far too slow. Long-acting muscarinic antagonists, the anticholinergic add-on. They block M3 receptors, shut down that vagal bronchoconstriction, and cut mucus, because they work on a totally different pathway from beta agonists. They stack nicely on top. Tiotropium via Respimat is your best evidence agent in asthma. Side effects are classic anticholinergic, dry mouth mostly, but watch for blurred vision, urinary retention, and be careful in narrow angle glaucoma. Where does it fit? Add on a GINA steps 4 and 5 on top of ICS LABA, making triple therapy. And one exam trap summer. Hypertropium is for acute attacks. Tiotropium is the LAMA for chronic control. Don't mix them up. Leukotriene modifiers, the oral option. Montelukast blocks the cis-LT1 receptor. Xylaton shuts down 5-lipoxygenase upstream. The big win is Conveniencer, a once-daily tablet, a no-inhaler technique to master, or great for allergic rhinitis and exercise-induced symptoms. But, and this is huge, Montelukast carries an FDA boxed warning for serious neuropsychiatric effects, mood changes, agitation, even suicidality. You must counsel patients and families before you start it. It's less effective than ICS, so think of it as an add-on or alternative, not a replacement for your steroid backbone. Reserve it for when the benefits genuinely outweigh those risks. Theophylline, the old timer with a dangerous edge. It's a non-selective phosphodiesterase inhibitor that bumps up GMP, plus it antagonizes adenosine, giving you bronchodilation and a touch of anti-inflammatory effect. Sounds great until you hit the safety profile. This drug has a narrow therapeutic index, target roughly 5 to 15 milligrams per liter, and above 20 you're into seizures and fatal arrhythmias. Worse, it's metabolized by CYP1A2, so it's an interaction minefield. Ciprofloxacin, macrolides, and cimetidine push levels up, smoking and rifampicin drop them. My mental shortcut: narrow window plus many interactions. Start a new CYP inhibitor. Recheck the level. That's why it's later line now. Oral corticosteroids. Powerful but handled with care. Their main role is the short burst, prednisolone 40 to 50 milligrams a day for 5 to 7 days in an acute exacerbation. Oral works as well as AV, so go oral if they can tolerate it. Short bursts usually need no taper, long courses do, and you never stop chronic steroids abruptly, or you risk adrenal crisis. The problem is cumulative exposure, osteoporosis, diabetes, cataracts, weight gain, infection. Here's the pearl: 2 or more bursts a year screams uncontrolled asthma. That's your cue to escalate the controller and think about referring for a biologic to spare those steroids. Now the exciting frontier: biologics. These are reserved for severe, uncontrolled asthma despite high-dose ICS-ABA, and the whole game is phenotyping. 3 biomarkers guide you: blood eosinophils, total IgE with allergen sensitization, and phenol, your exhaled nitric oxide. High eosinophils point you toward anti-IL-5 and dupilumab. Raised IgE with a perennial allergen makes you think omalizumab. High phenol flags IL-13 activity and supports dupilumab. But before you inject anything, stop. Confirm the diagnosis, check adherence, check inhaler technique. So-called difficult asthma is very often just untreated asthma, not truly severe disease. Get that right first. Let's match the target to the patient. Omalizumab is anti-IgE for allergic asthma with high IgE, and bonus, it treats chronic urticaria. Mepolizumab and rislizumab are anti-IL-5 for eosinophilic asthma, cutting exacerbations and sparing steroids. Benralizumab hits the IL-5 receptor and basically depletes eosinophils outright. Dupilumab blocks IL-4 and IL-13, perfect for eosinophilic or high phenol patients, and it also treats eczema and nasal polyps. And tezepelumab, anti-TSLP, is the broadest. It works even when the type 2 biomarkers are low. My rule for choosing: let the comorbidities decide. Nasal polyps or eczema, go dupilumab, sky-high eosinophils, anti-IL-5. Allergic, omalizumab, low biomarkers, tezepelumab. Here's something that gets criminally overlooked: the device. You can prescribe the perfect drug, and it does nothing if it doesn't reach the lungs. 3 options: the pressurized metered-dose inhaler, which needs slow, coordinated breathing. Always add a spacer. The dry powder inhaler, which needs a quick, deep pull and is useless if inspiratory flow is low, like in the very young, the elderly, or an acute attack. And the nebulizer for severe attacks, no coordination required. Get this stat up to 70 to 80% of patients use their inhaler wrong. So technique is a controller in its own right. Check it at every single visit before you escalate, and rinse and spit after ICS to dodge that thrush. This is the heart of modern global guidance, GINA's two-track approach. The foundational change, SABA only, is gone. Every patient from step 1 gets ICS containing therapy. Track 1 is preferred. The reliever is as needed low-dose ICS formoterol all the way up. Steps 1 and 2 you use it purely as needed. Step 3 you move to MART, daily plus reliever. Steps 4 and 5 you go medium, then high-dose MART, adding tiotropium or a biologic. Track 2 is the alternative, using an as-needed SABA. Pick this when adherence is a real concern. Master Track 1 and you understand where asthma care is heading globally. Now let's cross to the United States. NAEPP's 2020 update, EPR4. The headline is a SMART, single maintenance and reliever therapy, which is just the US name for MART. Same ICS formoterol concept, but here's how it differs from GINA through SMART, only kicks in at step 3 low dose, then medium at step 4. It's daily ICS plus as needed SABA. And crucially, GINA prefers CS formoterol reliever at every step, while NAEPP restricts it to steps 3 and 4. Why the caution? Because ICS formoterol as a reliever is off-label in the US. Same tools, more conservative positioning, and it's basically driven by regulatory status. Over to the UK and a landmark moment, the 2024 Joint Guideline, NICE NG 245. For the first time, BTSS, NICE and SIGN got in a room together and produced one guideline, replacing all that fragmented, older guidance. The distinctly British flavor, a heavy emphasis on objective diagnosis. You confirm asthma with FeNO, blood eosinophils, and spirometry with reversibility before you treat. They use their own MART-based pathway with ICS formoterol. Note what it doesn't cover. Severe asthma and acute attacks live in separate pathways. It historically diverges from GINA on step structure and thresholds, so always check the current NICE pathway for exact UK doses. Let's put all three side by side, because exam questions love the differences. Preferred reliever. GINA says ICS formoterol at every step. The US uses SABA until step 3, then SMART. The UK uses ICS formoterol in its MART pathway. The naming GINA and the UK say AIR or MART. The Americans say SMART. Do all three ban SABA only? Yes, universally. Biologics, GINA covers them at step 5, NAEPP doesn't address them. The UK puts them in a separate pathway. But here's the common ground that matters most: ICS for everyone, SABA only rejected everywhere, and ICS formoterol embraced as an anti-inflammatory reliever. And they differ mainly on how strongly and how early. Okay, gear shift. Someone's crashing in the emergency department. First, assess severity. Feb 1 or peak flow is your strongest predictor, plus oxygen sats, speech, accessory muscles, and mental state. Watch for the killers: silent chest, exhaustion, drowsiness, a rising CO2. That's impending respiratory failure. Then hit the first hour bundle. Oxygen titrated to sats above 90. Salbutamol 2.5 to 5 milligrams, nebbed every 20 minutes times 3, continuous if severe. Add apretropium in moderate to severe attacks. Systemic steroid within the hour. Oral equals 4. And magnesium sulfate 4 for the severe refractory cases. No response. 4 beta agonist. consider non-invasive ventilation and get ICU involved. Antibiotics are not routine. A few special situations that trip people up. Pregnancy, the golden rule is keep the asthma controlled, because uncontrolled disease is far more dangerous to mom and baby than the drugs. ICS, especially budesonide, plus SABA and LABA are all considered safe. In children, ICS stays first line. Just watch growth and technique, and MART is endorsed from around age 4 to 6 with age-appropriate devices. Exercise-induced for exercise SABA or regular ICS, and don't forget a warm-up and aspirin exacerbated respiratory disease. That triad of asthma, nasal polyps, and NSAID sensitivity. Avoid NSAIDs. Leukotriene modifiers help, and consider a biologic. Stepping up or down, do it systematically. Before you ever step up, run the checklist. Is the diagnosis right? Are they actually adherent? Is their inhaler technique any good? Any untreated triggers or comorbidities like rhinitis, reflux, or obesity? Fix those first, then escalate one step. Stepping down is just as important. Only once they've been well controlled for at least 3 months. Reduce the ICS by 25 to 50% at a time, and never withdraw the ICS completely. Monitor with ACT scores, spirometry, exacerbation history, and reliever use. The golden rule: the lowest effective dose that maintains control, with ICS always retained. Rapid fire time: the high yield do's and don'ts that win you marks and save patients. To give ICS to every asthmatic, even mild disease. Do prefer ICS formoterol as the reliever where you can. Do check inhaler technique and adherence every visit. Do counsel on montelukast's neuropsychiatric risk, and do treat exacerbations early with systemic steroids. Now the don'ts: never prescribe a LABA without an ICS. Don't rely on SABA alone. It masks the worsening inflammation. Don't escalate before checking technique. Don't forget to rinse after ICSS. And don't ignore frequent steroid bursts. That's your signal to refer for a biologic. Alright, let's test you. Pause the video and have a real go at these. Question 1. A 24-year-old with mild asthma uses her salbutamol about 3 times a week, no controller at all. Per GINA, what's the single best next step? Is it A, keep the Sabal alone and review in 6 months? B, start as needed low dose ICS formoterol. C, jump straight to daily high dose ICs. Or D, add oral montelukast as monotherapy. Think about everything we just said about SABA-only therapy. I'll give you a moment and we'll review all the answers together in a few slides. Question 2. This one's a classic safety question. Which controller must never ever be prescribed as monotherapy in asthma because it increases the risk of asthma-related death? Your options: A, inhaled corticosteroid. B, long-acting beta-2 agonist. C, leukotriene receptor antagonist. Or D, long-acting muscarinic antagonist. If you were paying attention to the black box warning earlier, this should be an instant reflex. Lock in your answer and let's keep moving. Question 3. A patient you've just started on a controller comes back reporting new agitation, low mood, and disturbed sleep. Which drug carries an FDA boxed warning for exactly these neuropsychiatric effects? A. B. Montelukast, C. Budesonide, or D. Tiotropium. This is a pure pattern recognition point, and it's a favorite in exams. Commit to your choice. And question 4, let's flex that biologics knowledge. A severe asthma patient has blood eosinophils of 600, nasal and coexisting atopic dermatitis. Which biologic best fits this phenotype? A. Omalizumab anti-IgE, B. Tupilenti IL-4 receptor alpha, C. Theophylline, which obviously isn't even a biologic, or D. Tezepelumab, but only if biomarkers are low. Think about which comorbidities point where. Got your 4 answers? Let's review them now. How did you do? Question 1, the answer is B true. SABA only is obsolete. So you start as needed low dose ICS formoterol GINA track 1. Question 2, also B. LABA monotherapy raises asthma death risk, so it's always combined with ICS. Question 3, B again. Montelukast and its boxed neuropsychiatric warning, cancel before starting. And question 4, Birdupilumab, because it's perfect for eosinophilic disease with nasal polyps and eczema, blocking IL-4 and IL-13, and it's licensed for all 3. 4 Bs in a row. If you got them all, you've genuinely mastered this. Let's lock it all in with the 10 essentials. 1. Asthma is inflammation plus bronchoconstriction. Treat both. 2. ICS is the anti-inflammatory backbone for everyone. 3. SABA only is obsolete. 4. ICS formoter as marked cuts exacerbations. 5. A LABA never goes without an ICS. 6. Add tiotropium as triple therapy when you step up. 7. Montelukast means the boxed warning. Theophylline means narrow index. 8. Biologics target type 2 pathways in severe disease. 9. The acute attack cry, oxygen repeated SABA plus epratropium, systemic steroids and magnesium. And 10. Always check technique, adherence and step down when stable. And that's the full picture. The pharmacotherapy of asthma, from mechanisms all the way to the emergency department. Everything today is grounded in the Big Four GINA's 2024 and 2025 reports, the US NAEPP PPR4 update, the UK's NICE NG245, plus the BNFDA labels for the specifics. But remember, this is an educational resource, so always confirm exact doses, contraindications and step recommendations against your up-to-date local guidelines before you prescribe. If this helped your revision, smash that like button, subscribe for more, and drop your questions in the comments. Thanks for watching. I'll see you in the next one.